from me attempting to explain why we can use bee venom in a hospital setting where I work. And I did actually convince them, and we are utilizing it in our pain center. We can talk a little bit about that. So I want this to be a little more clinical focused, and that's how I'm going to approach this lecture, even though we will go over some of the research. So the concept of pain means many things to many different people. It's a multifaceted problem, and in the way that I approach pain and how our center approaches pain, it really is a disease unto itself. There's a lot of things that go into chronic pain, and that's what I'm going to be focusing on, is chronic pain. The basic overview is that it's a mind, body, spirit disease. And it encompasses and affects all of those factors. Chronic pain specifically is the leading cause of disability in the United States. It's becoming an increasing problem. We're seeing a lot of chronic pain issues with geriatrics. For those of you in gerontology or primary care, they present with a lot of problems. Pain being one of them, but in addition to a multitude of chronic disease. We're also seeing, at least for those, I know many people are from other countries, but here in the United States, unfortunately, we're seeing a lot of young people returning with very significant pain problems because they're veterans, both peripherally mediated from injury and centrally mediated from blast injuries and things of that nature, as well as the psychological trauma and psychic scarring that's occurred from the war. Management of chronic pain and the approach to it is a very difficult problem. As much as we have available, quite frankly, the options are limited. We're clinically guessing a lot of times, and we're hoping for the best outcome. We're switching drugs, we're switching mechanisms, we're switching classes. There's a lot of comorbid pathologies that are involved, and how we treat it is often impacted by those things. We have drug-drug interactions, drug-herb interactions, side effects from the drugs we're using, particularly the main class of drugs we have for pain, being opioid, comes with a lot of side effects. These things compound the picture, leads to a lot of quality of life issues, impacts nutritional status, ultimately ability to perform activities of daily living, etc. So pain management overall requires a very comprehensive integrated approach to address those multifactorial problems. Apitherapy is a way to augment the conventional therapies and ameliorate some of those cumulative side effects that we see clinically. I'll skip some of the introduction parts. We have had a lot of repeat slides, so I won't bore you. But I am always fascinated that independently, over 6,000 years, many of the main cultures utilize this therapy, and it's in most of the traditional texts. Bee venom, which I'm going to primarily talk about, is a subset. Primarily two species, Apis mellifera and Serrana, depending on where you are in the world. As Dr. Kim alluded to, it's sometimes referred to as apipuncture, and that's how I approach it clinically, and that's how we're going to talk about it here in this lecture. Because it can be administered in a multitude of ways. Primarily, the sting from a live bee is how most people are familiar, but also via injection. The topical applications, although effective because they have the pharmacological effect, I would suggest eliminates potentially up to 50% of the action because we eliminate the mechanical application. This is a combined mechanical and pharmacological therapy. These things act synergistically together, and what we can produce is both a central and peripheral inhibition of pain. So bee venom thus becomes a novel therapy and potent tool for a very difficult problem. It's not unheard of clinically, certainly not for traditional people, as we said, it's 6,000 years old, but now we are actually having a scientific sort of rationale for it. There's a FDA-approved drug called Prialt, ziconotide, which is derived from the Conus magnus cone snail toxin. It's synthetic. It's a reproduction of that molecule. It's isolated. It's a calcium channel blocker that inhibits pain. It's available. It's only delivered really intrathecally from an intrathecal pain pump that's implanted into the patient and a catheter that runs directly into their spine. So direct sort of comparisons are a little difficult, considering one's going directly into your spine and one's getting put dermally. But it does give us some rationale for the use of toxins, and there's obviously a long historical record of using toxins, scorpion in many cultures, toad skin, etc. Bee venom is very complex. We don't understand all the molecules, though we have identified many of the main components. We know that it has a direct analgesic effect, and it also, importantly, affects the contributory mechanisms to pain. Again, remember I said there's a lot of things happening that cause pain. Bee venom addresses quite a number of them. In addition to the direct analgesic effect, it also impacts inflammation, oxidation, histamine release, and the immune system, which is why we see it often used in autoimmune conditions. So traditionally, there's a traditional view of pain, for those of you that are traditional providers, basically related to a concept of impediment or stagnation. And those things are referred to as bee syndromes when they're chronic. And what's interesting about that is that they're categorized by their presentation, okay? The total symptom picture, and then treatments are designed around that. Bee venom therapy mimics many of those traditional therapies that were used for thousands of years to treat those various conditions specifically. We have counter-irritant effect, we have distal point stimulation effect, the use of heat, and the extravasation of blood. So these are all common treatments that were applied historically in many cultures, not just Chinese medicine, for the treatment of pain. And so bee venom here incorporates most of those in one nifty little package, if you will. In addition to the scientific, which we've been talking about primarily in regards to bee venom, there is traditional or energetic or herbal characteristics associated with the venom. I extrapolated this based on the work of a French acupuncturist who sort of wrote some musings around this concept, and I extrapolated on that. I know everybody in here isn't necessarily interested in Chinese medicine, but what's interesting from an herbal perspective is that it has this very dual effect, and we're going to see that as we go through the actual science. For those of you that are, it impacts both yin and yang, and we would say traditionally that it enters all of the organs of the systems. So it has a very broad and potent effect. Here I made some here's traditional herbal actions that we ascribe to herbs, and I made the biomedical correspondence to what bee venom would do in regards to that. Because what I really want you to see is how we can walk away clinically. I know that people are interested in the science, and I want you to walk away thinking the science is solid, but I also want you to walk away saying, this is a viable treatment option. We can do this. So what I want you to do is look at this like a hybrid therapy, because that's what this is. It's a hybrid both in its concept and its physical synthesis, okay? It's both traditional and modern in how we can approach the use of bee venom therapy. And I would caution to not completely disregard the traditional impact of this, which could be somewhat reductionist, because it does approach it in a different way, in a different evidence-based model, and often I have to, in my own practice, sometimes step out of my Western hat because, frankly, we can't fix them, I can't figure it out, and I say, okay, I'm going to do a traditional evaluation, and that's how I'm going to treat you. Not that that always works, but it gives us another ability to redirect our diagnostic skills and try to intervene. So what does a hybrid therapy mean? It's an external therapy, essentially in the form of acupuncture. We're stimulating a point, we're puncturing a point with either a stinger or a needle. And then we have an internal pharmacodynamic effect, which you can view either as strictly biochemical or herbal or both, as I do. So why does this work? Acupoint stimulation, in the sense, this portion of bee venom is related to acupuncture, and the analgesic effects of which are multifactorial, pretty well established in the literature. In fact, to such a degree that the World Health Organization has made the statement that for chronic pain, the analgesic effects of acupuncture are equivalent, if not better in some cases, to chronic opioid use, which is a fairly powerful statement. Basic mechanism of pain control is the classic gate theory, which has since been sort of upgraded, which has to do with signaling fibers, the fast fibers overriding the slow fibers, gating mechanism in the spinal cord. But the important part of the puncture part of bee venom therapy is that we actually have a central mediated response. It activates almost all, probably not all, but let's say the three main opioid receptors in the spine and brain. It's very important. Most pharmaceutical drugs, mu is considered the most powerful receptor, the primary target of most pharmaceuticals. And acupuncture and point stimulation will activate that. Excuse me, but it also activates the other. In addition to that, it's known to activate the pituitary gland, which is obviously a major component of the hypothalamus pituitary adrenal axis, which provides a much broader effect, and that's where we start seeing the activation of those nonspecific or contributor factors to pain. It does that primarily by acting on these two pathways, the serotonergic and the noradrenergic pathways into the brainstem, which we're going to talk about. But the takeaway message is that centrally acting effect. Okay? The second mechanism is DNIC, or diffuse noxious inhibitory control, which I just like saying. Essentially, you make something hurt to stop something else from hurting. That's basically the bottom line, okay? And we've seen this, and many of you, I bet, would probably use it. Capsaicin, cream, things like that are counter-irritants that produce this DNIC effect. If somebody gives a TENS unit, there's some of that mechanism involved, okay? We see this a lot, and again here, we've demonstrated DNIC inhibition through mechanical stimulation, heat, and the injection of saline individually, okay? Some of which activate substance P, okay? There's substance P sensitive fibers that we now call capsaicin sensitive fibers. Substance P is a primary neurotransmitter responsible for pain. It's found everywhere in the body. And we're just learning how really potent that effect is. Depleting that neurotransmitter inhibits pain over time. What's interesting is that the acute part, the sting part, okay, of bee venom induces all forms of DNIC. This is a little drier, but this is the internal part. FOS expression, a protein expression in the brain. What we see with bee venom is that following bee venom, we can measure increased expression in the brain, which is a marker of activation of the descending spinal tracts, which cause peripheral nociceptive inhibition. What that means, what does all that mean? We give the venom peripherally, it causes an upregulation of this protein in the brain, which activates these descending pathways, which shut off the pain distally. Okay? And there's a bunch of research around that. And here, that's essentially what I'm saying, is that envenomation can actually mediate this process. Interesting point, and this is why I wanted to approach this clinically and hopefully sort of give you that traditional science blend. So we can induce this process with venom, and we can induce some of it with acupuncture and saline, but we can make it even more potent if we utilize the bee venom on traditional points. And that's against control, point to non-point. So sure, we can get inhibition by using envenomation on the body, but we can improve it if we do it on specific points. A blending of the tradition and the science. Okay, contributory mechanisms. Those were the central mediating effects. Peripheral mediating effects, anti-inflammation. We know that it inhibits, laser. We know that it does have a potent anti-inflammatory response or action. It inhibits nitric oxide synthase fairly strongly and fairly quickly, and ultimately leads to COX-2 inhibition, which is the primary site of what typical NSAIDs or non-steroidal anti-inflammatories would target. So we know that this is a viable clinical target. This is our main target as a first-line treatment for pain. We also show increases in the production of inflammatory cytokines, okay, which lead to progressive inflammation. Things like interleukin-1 beta and TNF-alpha. Okay, this is one study and one study only, but it was confirmed later. But bee venom actually did better, equal to or better than some of the standard anti-inflammatories that we use, both non-steroidal and steroidal. So in head-to-head comparison, now time was not a factor. The dose-dependence relationship was not included in this, only the immediate effect. But it's interesting that it had a very similar effect. So, and we can prove that with the science and that COX inhibition. But it was potent enough, even without measuring the dose-dependent relationship. They did radiographic studies and showed that when they induced arthritic changes in animal models, they can markedly improve the arthropathy that's present. It also is shown to significantly sustain cortisol levels. Now, as you can see, very old study. And often, at least in natural medicine, holistically minded MDs, cortisol is a problem, especially in contrast to the obesity problems, the hormone problems, the neuroendocrine disruption that's occurring in the United States. Cortisol's sort of been a problem, cortisone depletion. What we find with bee venom is that it acts more as an adaptogen. It's more of a modulator over time because of that. If you remember when I talked earlier about the effect on the pituitary and its overall impact on the hypothalamus axis, we see more of a modulating effect. That's important because, again, going back to an herbal model, that's how many of the herbs work. The ginseng class, licorice, they prolong the action of cortisol, increase in levels of cortisol. And they have a more modulating effect on the body, regulating the sympathetic tone of the sympathetic and parasympathetic systems. Immune response. We know that, or at least we suspect strongly in chronic disease, that there is a direct immune imbalance. Now I think they're up to something like Th4 in terms of branches of the immune system. But the primary sort of counterbalance of the immune system is THC in autoimmune diseases particularly and severe allergies, is that we have a dominance of Th1 and the Th2 response is suppressed, and that, because Th2 is suppressed, it drags Th3 down as well, and Th3 is our primary tolerance to the outside environment, which is why we see heightened reactivity. Bee venom directly influences this, and it does this in an interesting way. There's not a ton of studies on it. They've done some studies with actually using venom in some sort of swine production to increase their immunity so that they would have less piglets die, and then they measured it. But we can see that it causes a T cell response, but it causes it without actually having an antigen presenting cell activated. So it suggests an independent genetic pathway shift in some way. So we don't get the whole immunization of CD4 helper cells to selectively differentiate into those pathways. So it becomes a pretty potent tool. So in summary of this portion, in that concept of the blending, B-Venom's pretty powerful. We've got direct central inhibition, we've got peripheral inhibition, and we've got a strong effect on the contributory mechanisms of pain. So we really are affecting a system-level change in addition to treating the primary problem. As we would say in Chinese medicine, that's treating both the root and the branch of what's going on. Okay? And so we see that, like I just said, we've got a mechanical effect, we've got a pharmacological effect, centrally mediated effect, and the contributing effect. So although still considered experimental, though I would say we say that only for protection, I think the research is pretty solid from Dr. Kim and from others. There's a long history, certainly a very strong empirical history, extensive amount of positive research involved that we've heard about. And I think it justifies itself as a novel treatment of pain. And I would even suggest, since I am in pain management, there's statistically, we don't have that many stronger, we often, how can I say this delicately? We often use things off-label because we don't have other options. So I would suggest that this isn't that much different of a concept. Okay? So how do I do this? I know people have gone over this, so I won't, but obviously we testing everybody. If they have a history of hypersensitivity, they're eliminated. We have a desensitization protocol. I do not do that in the hospital setting or the clinical setting. I got yelled at for saying large muscle fatty area by my other apitherapists who do it on the arm. I don't really know the answer, but we test somewhere. You can either retain the stinger, as Teo said, or use a half dose of the injectable. I mix it with a long-acting and a short-acting anesthetic, lidocaine and marcaine, and spray them with cold. I select points based on the condition, and I do point selection, how I would choose acupuncture points, but also what would make sense biomedically. Lumbar nerve roots, spinal nerve roots, location of pain, joint, etc. So, and then clinically we decide, on the number of things based on the response, how long the condition's been in place, etc. These are the things I'm primarily using it for in our clinic. Central pain states, fibromyalgia. I have not attempted it on complex regional pain syndrome as yet, though I have somebody that's interested because he was injured during an abdominal surgery and caused a complex regional pain syndrome in his foot, and we cannot block it with a stimulator because he's still undergoing surgeries and radiation. So we're going to attempt the B-Venom on him. I use lower dose for things like fibromyalgia-like states, post-surgical symptoms, as Dr. Kim spoke about. Rheumatoid and autoimmune, I'm doing it for a couple of MS patients. And obviously many of our patients have severe arthropathies. How do I employ this? I employ it in a multidisciplinary manner. It's one tool in the toolbox. Ooh, got cut off. But again, comprehensive approach. Utilizing all these things gets us better outcomes for chronic pain. We try to be goal-oriented. We do, as a rule of thumb, at our clinic at least, attempt to get people on the lowest dose of opioid or off opioids altogether. We implement it in a stepwise approach, looking at pain as an onion. Impact of the immune system, inflammation, how much is centrally mediated, etc. What levels we can do. We build an individualized treatment for that and create a therapeutic order, and we do that basically using a treatment pyramid. We baseline medications, we optimize them, add in extensive rehabilitation, both physical therapy and occupational therapy. Then we add in mind-body, cognitive behavioral therapy is a main focus, mind-body medicine, everything from hypnosis to biofeedback to heart rate variability. We're working on getting some spiritual intervention. We don't have it at the moment. Of course, interventions in surgery, if we can fix something, we fix it. Of course, we have all the epidural injections, nerve blocks, etc. And then I add in the CAM element. Sometimes acupuncture. I am admittedly a little judicious with my use of bee venom. I sort of self-select the patients who have at the end of their rope so that I get a little more buy-in. And then we add in herbal medicine and nutrition. But the concept being that disease is a pain that requires the entire process. Bee venom is a piece of this. It's a powerful treatment. And we do. Questions? All right. Well, thank you very much for allowing me to speak. I appreciate it.